Now, our first speaker today is Dr. Kaz Nakagawa, a highly accomplished neuro-intensivist. I had to practice that word. His clinical care, teaching, and research have all been recognized with many awards from his colleagues and our medical students. His teaching style is described as dynamic. The most recent award, which is not in his bio, is the Queen's Hospital-based Physician of the Year Award in 2019. You may also see him surfing early in the mornings. I won't, but maybe y'all will. So please welcome Kaz.
Good morning, everyone. It's a true honor to be here today to give this talk to all of you. Thanks for coming today on Saturday morning. So I'm going to talk a little bit about stroke, how we treat acutely, and how we can prevent stroke, and that's what we want to know here. So my only disclosure is that I'm one of the investigators for Center of Aging with Dr. Masaki over there. Excuse me. And just to give you a little bit about my background, I'm a neuro-intensivist, so I'm a neurologist with ICU trainings, and we have a neuro-ICU at the Queen's Medical Center, so I oversee that. As well as I oversee the Comprehensive Stroke Center at the Queen's Medical Center. So what is stroke? So stroke is when you get a blockage of one of the blood vessels in the brain, and when that happens, there's no more blood flow to that part of the brain, so you have no oxygen and blood going to that part of the brain, and then it starts to get damaged. And blood vessels in the brain are like tree branches or the roots, where it starts out with the big roots or main trunk, and then goes into the medium size and smaller size branches. So if the clot is at a very, very small distal, small little fine branches, the stroke is really small stroke, mini stroke. But if the clot is relatively big, gets stuck in the very proximal, so closer main pipe, sort of like this, then the area that gets impacted is much larger, and you get a big, severe stroke. And over time, that part of the brain gets damaged and disappears, just like you see on this picture. So where does that clot come from? Well, this is the picture of the person's head and the heart. And so the blood vessel comes from the heart. Heart is the main pump. And you can get a stroke when small blood vessels inside the brain gets narrow over time with conditions such as high cholesterol, diabetes, high blood pressure, smoking, and so on. Same physiology as when you get a heart attack, so cholesterol plaque build up in the heart. Same thing can happen inside the brain, where over time you get this cholesterol plaque, and then one day it may cause a rupture and cause a clot formation, and you can have a small stroke or big stroke. Other reason is when you get a blockage in the carotid artery. So carotid artery is a main artery that goes in your neck. That's the connection between the heart and the brain. And people who are smokers and also people with high cholesterol can develop this cholesterol plaque inside the carotid artery over time, and that can get thicker and thicker over time, and one day can cause blockage, or sometimes it forms a clot around the cholesterol plaque that gets dislodged to the brain. When this gets discovered before having a big stroke, we can do something about it. We can do a surgery to take out the plaque, sort of like what you see here. That's the cholesterol plaque that was surgically removed to prevent further stroke. If someone is a high risk for surgery, going into the OR with this general anesthesia, we can alternatively do carotid stenting. So similar to how the cardiologist puts stents inside the heart, we can put stent in the carotid artery, so keep everything open. Other etiology for stroke, even if all the vessels, all the pipes in the neck and brain are fine, sometimes you can have a heart condition that can predispose you to have a clot inside the heart. And when that happens, we call it thrombus, but it's basically a blood clot that forms inside the heart, that can get dislodged and goes all the way through the neck and gets stuck in the brain. And that's another cause of stroke. So if you have a certain heart condition, such as atrial fibrillation, which is irregular heart rhythm, or heart failure, or recent heart attack, those increase the risk of forming a clot inside the heart. This is a video of echocardiogram, so ultrasound of the heart, that's showing this is a clot that's stuck in between the wall of the heart that's about to get dislodged. There's a small hole in the wall of the heart. It's called patent foramen ovale. About 25% of the population have that. It's not a big deal. 1 out of 4 of you will have this small hole in the heart. We're born that way. It's not a big deal. But sometimes a clot can go through that hole, and this is really like octopus going through a small hole. You know how the octopus can travel through a small hole? It's sort of like that. So how do you recognize a clinical sign of stroke? There's an acronym called FAST, F-A-S-T. F stands for face. So if you recognize someone having, or yourself having a facial droop, that's a sign of stroke. A stands for arm weakness. So any kind of arm, even a little drift, clumsiness. Obviously, if one side is paralyzed, that's obvious. But even some clumsiness, you're dropping your pen, fork, utensils, that's a sign of stroke. Speech difficulty. It could be garbled speech, incomprehensible speech, problem finding the words, can't even enunciate, or even if you can speak, it's just slurred. And T stands for time. It's just time is brain. You gotta call 911. And we'll go through each one right now. So these are the sort of cartoon picture of someone having a stroke. So facial droop. The key is looking at the lower part of the face. That's the most prominent part of the face that can cause a sort of an asymmetry when you're having a stroke. Much less on the upper portion. And arm, again, like I said, it doesn't have to be the obvious paralysis. It could be as subtle as a little drift or clumsiness. And even if you feel like, it's not a severe weakness, it can potentially progress into severe weakness. So you want to get it checked out as soon as possible, even if you feel like the symptoms are relatively mild. This concept of time in the brain is that every minute really counts. The faster we provide treatment, the likelihood of you being independent after the treatment goes up. And the time that we quote is 2 million brain cells every minute. So every minute during a stroke, you're losing about 2 million brain cells. And that's why when I'm in the hospital on call for stroke, if they announce acute stroke team, I literally drop everything. If I'm seeing a patient or family, I say, I have to go. I drop everything and literally run down to the ER because I know every minute counts. So that's why it's important to call 911. The good news is that, actually, if I were to give this talk back in the 1990s, I would have said there's nothing we can do. If you have a stroke, we could have just focused on the physical therapy and move on. But luckily, in 1996, we developed a clot buster medication called IV TPA, tissue plasminogen activator. And this is really a clot buster medication that dissolves the clot if you give it in a timely fashion. It works about 30% of the time. So 30% of the time, patients get better significantly. About 5% of the time, they may get some kind of bleeding complication. And the other time, we give the medication and nothing happens. And it's not really because the medication doesn't work. It's usually we gave the medication, it was kind of too late. The brain damage was already there. Okay. So it breaks up the clot. The concept is sort of like having a Drano. If you have a clogged kitchen or bathroom drain, you're going to put Drano. Hopefully that's going to declog, but it doesn't work 100% of the time. Half the time you have to call the plumber or do something, or ask your son to go fix the pipe, right? So Drano is good, but it doesn't work every single time. So what do you do when you get a big clot that's sitting in the main pipe? By the way, the TPA, the clot buster medication, works for relatively mild to moderate strokes when the clot is relatively small, somewhere distal, and that's when the brain Drano works. But what about a big clot that's hard, long, thick? Usually the Drano doesn't work, right? So there's another treatment called thrombectomy. So this is more of a little bit more invasive procedure. It's sort of like the cath that cardiologist does, where we would puncture from the groin. Now we can do it from the wrist, but thread a microcatheter wire from the groin all the way through the aorta, through the heart, through the neck, to the brain, to that clot and then basically deploy a stent or have an aspiration device and get that whole thing out. And we can do it very fast. And that's what the stent would look like. And we do have a dedicated neuro-interventional team who would perform procedures like this at our medical center, and we have this at 24/7. And this is what the procedure team would look like. And this is what this is a CAT scan with a contrast of someone having a big stroke. So you can see here that basically these are the blood vessels. This is the left side of the brain. This is the right side of the brain. It should be a mirror image. And this arrow points the absence of this blood vessel. So there's a big clot sitting there preventing blood flow to the left side of the brain. And after that treatment, you can see the restoration of the blood flow here like this. And that's the kind of clot we would pull out. And really, this has been a game changer. This thrombectomy has been around for less than 10 years. Well, the technology was there before then, but it really became like in the standard care of the last maybe 5 to 7 years. When I came here in 2010, we weren't doing this really here, maybe occasionally, a couple cases, but now we're doing this all the time. And we used to have a lot of severe stroke patients where we couldn't do anything, where we just gave the TPA, the clot buster medication. They didn't really get better, and they're very severely disabled. Some of them passed, and then some of them had to go to a nursing home permanently. But now, with a thrombectomy, about 1/3 of the patients are going home straight from the hospital like the second day because they're that much better. And about 60% of them are going either to acute rehab because they're really good, and not that many people are very disabled because of this procedure. The most important thing that was published 2 years ago was this big trial that showed that we can actually provide this treatment up to 24 hours of symptom onset. All the clot buster medication trials were very time sensitive. We were giving clot buster medication up to about 3 to 4 hours, 4.5 hours from symptom onset. Even this thrombectomy, until this trial, we were limited to up to 6 hours of onset. Okay, so we count the clock, we start the clock the last time we saw that person normal. So let's say if someone went to sleep at 10 p.m. and woke up at 6 a.m. with a severe deficit, we would say the onset was 7 hours ago. Wait, 8, did I do the math? 8 hours ago, right? Yeah. Or 7 or 8 hours ago, and that would be excluded. So a lot of the patients who would wake up with a stroke deficit and the family saying, oh, like my mom went to sleep at 10 p.m., we weren't providing treatment. But now, with this 24-hour window, we can consider the treatment. And not everyone would get it. Some people, when they come, it's too late, but we can determine that now with advanced neuroimaging. So there's a fancy way of determining. We learned that we used to have this sort of time is brain, and everyone within so many hours gets it or not. We learned that everyone's very different. Some brain can last for many hours without having a big permanent damage. Some people have a brain that just doesn't have a lot of helper blood vessels, and even after a few hours of stroke, everything is already too late. And we can determine that with a special imaging that we provide. So this is a picture, a mirror image, that the green area is the area of the brain that's not getting the blood flow right now, okay? Pink area is the already damaged brain tissue. So there's a mismatch. So any area that's green but that's not pink, that's the brain tissue that we can still save with thrombectomy without treatment. Now, if this picture was all pink, just matching this green image, that means it's too late. There's nothing really to save. And this is the way for us to select people even up to 24 hours. Some people can get the treatment. And really, this gets spit out after the CAT scan, comes into our email, like instantaneously, a picture like that on the phone. And it tells you that 6 milliliter of brain tissue is already damaged. There's about 82 milliliter of brain tissue that's not getting blood flow. So if you subtract 6 from 82, there's still 76 milliliter of brain tissue that we can still salvage. And we say that's a go. Let's go do the treatment. So we talked about the importance of calling 911. And you may wonder, or you may, let's say if you or your loved one's having a stroke, you recognize the FAST acronym, facial droop, speech problem, arm weakness, and your son is saying, Mom, Dad, I can drive. I got the fastest car. H1's wide open. I can drive faster than waiting for the EMS, okay? I'll take you to the hospital. Don't do that. Call 911. Even if there's a little bit of delay for the ambulance to come, the reason is the treatment begins on the ambulance ride, okay? The other thing is that they're very good at notifying the strokes. They know which stroke center, which hospitals to take that person, the closest stroke-ready hospital, and then give them a heads-up alert so that stroke team can be ready, waiting for you. So when I'm on call for the stroke team, the best is when they page us saying, stroke team, stroke code, stroke team come to the ER, and we go down, the patient's not there, and we just wait. So as soon as the patient arrives, we just do everything instantaneously. CAT scan's ready, CT tech's ready, phlebotomist is ready to get the blood draw, ER has a room wide open, everyone's ready for you. Whereas if someone brings that person into the triage, drop off, there's a whole process of a nurse taking the triage and then calling the stroke team, and it may take us 5 to 10 minutes to get down sometimes. So there's gonna be a delay. So always call 911, okay? Don't worry about cost and all that. It's completely worth it. The other thing is that the thrombectomy, the clot retrieval procedure that I talked about, currently only our medical center provides that 24/7, so other hospitals don't. But that thrombectomy, we only do it for the big stroke, when the clot is very near the main pipe. It's not the small little stroke. So let's say if you live on North Shore, West Side, and so on, if you're having a small mini stroke that we're not gonna do a procedure anyway, you want the ambulance people to take you to the closest stroke-ready hospital. It could be Wahiawa, could be Queens West, could be Palimomi, okay? But if you're having a big stroke where you're most likely to need a thrombectomy, the procedure, you don't want to be wasting time going from hospital to hospital, because that's going to be like an hour or two of delay. So you want the ambulance to take you straight to the thrombectomy-ready hospital, which currently is only Queens. And so the ambulance people are very good at triaging stroke patients like that. That's why you want to call 911. They'll take you to the closest place that will provide the best treatment. Okay, so let's talk about how do you prevent stroke. We talked about what we do if you have a stroke, but let's not get there. The goal is to make sure that you don't have a stroke, or your loved one will never have a stroke. In reality, like 80 to 90% of the strokes are completely preventable if you do everything right, which is hard. Healthy lifestyle, control the blood pressure, don't smoke, all that. And I just want to talk a little bit about some medications. You may have some questions at the end. So if you have a very severe cardiovascular disease, or if you ever had a mini stroke or stroke in the past, it's important to keep taking antiplatelet therapy. So that could be aspirin, could be clopidogrel or Plavix, could be ticagrelor or Brilinta. These are sort of mild blood thinners, okay? And it's kind of beyond the scope of this talk today to tell you when to choose certain drug. But the bottom line is that if you had a mini stroke and so on, you should be on one of them, and you should talk to your primary care doctor, or preferably a stroke neurologist, to see which one's most appropriate. Now, like this ticagrelor or Brilinta is a stronger blood thinner than aspirin, so it may be more effective, but it can cause bleeding risk. So we balance the risk and benefit based on your overall profile. And sometimes we add two medications, so aspirin and clopidogrel, both. Because sometimes in certain trials it showed that doing both prevented stroke more effectively. But we also know that over time, if you take both medications indefinitely, your bleeding risk goes up. So there's like a good optimal cut point when to stop doing that. And again, it's a little bit beyond the scope of this talk today to say when to stop that. But the main point is it's a little bit complex, and it's important to see a neurologist to sort of go through this process. If you have atrial fibrillation, I don't know if you've heard that term, but it's an irregular heart rhythm. That is probably the number one heart condition that increases the risk of stroke. And people wonder, I don't understand, like heart is being irregular, how does that increase the risk of stroke? It's confusing, right? Like you guys nodding, right? I didn't understand for a while. So the way it works is that the blood that we have, okay, it's liquid, but it's not like water. It's not thin. It's thick. It's sort of like lava, or it's sort of like the cement. If it slows down, it solidifies. It has to keep moving. So it's a thick liquid that has to keep moving to stay as a liquid. If it slows down, it just becomes a solid or a clot. That's how it works. And what's keeping the blood from solidifying? It's our pump. It's our heart that's pumping all the time and keeping our blood moving and keeping it liquid, okay? Atrial fibrillation is when you have a little quivering of the heart, one pocket of the heart called left atrium. So you can see here that you have 4 chambers of the heart, the ventricles. So to the bottom one, the ventricles are the big pump. That's what really matters for the keeping the blood pressure normal and pumping the blood forward. And these small little chambers at the top, called the atriums, those are sort of like the getting ready chamber, like the blood goes in there before going to the ventricles. So they don't really act as a big pump, but it sets the heart rhythm. It's like the pacemaker chamber, okay? Atrial fibrillation is when this part of the heart starts to quiver, almost like when you get a muscle spasm. It just kind of happens out of nowhere. So that part of the heart, instead of pumping like this, atrium, it kind of quivers like that, okay? Why is that? So that causes the irregular heart rhythm. So how does that cause a stroke? Well, in that little pocket, if the heart is not doing this, but just quivering, that area gets stagnant. The blood just pools there. It's almost like, if you have a koi pond and if the water is constantly flowing, it stays as clear water. But if there's a little pocket, it's just not moving. That's where the green algae forms and gets all murky. So when the heart is quivering, blood just kind of pools there, and then sort of like the green algae formation, it forms a clot. And that's how, when that clot forms, it can get dislodged and go into the brain. Okay? So when you have atrial fibrillation, even if it's brief, some people may hear, I only have it sometime. The data shows that it doesn't matter if you have atrial fibrillation 100% of the time or occasionally, the risk is the same. And really the treatment is to be on the blood thinner. In the past, we only had warfarin, which is the level can go up and down. It's unpredictable. But nowadays, over the last more than a decade now, we have multiple new medications such as apixaban or Eliquis. You may have heard of that on the TV. Pradaxa or dabigatran, Xarelto or rivaroxaban. So all those are new full blood thinners. And they're much better than warfarin because they keep the blood thin, it's predictable. The bleeding risk is much lower than warfarin. Okay? And my next slide is pick your battle. So I just want to give you sort of a scale or scope of the impact of each of these risk factors. So we hear about, high blood pressure is bad, high cholesterol is bad, you gotta eat your fruits and vegetables, don't smoke, don't drink too much. But if you were to put an impact sort of score on which one gives the most contribution to having a stroke, by far it's high blood pressure. High blood pressure weight, like impact on stroke risk factor, is almost 10 times more than not eating fruits and vegetables, physical activity, or even compared to smoking. Or high cholesterol. We talk about statin, right? You gotta lower your cholesterol. I'm not saying it's not important, but look at the impact of focusing on cholesterol and high blood pressure. I see so many people who get fixated on the cholesterol level, yet their blood pressure is high. The top number being 160, 150s. Okay, and I'll show you. It may not be super high, but that little bit of high elevated blood pressure actually matters. Here it is. So this is the risk of having a stroke based on your systolic blood pressure. So the top number, it's a linear relationship, meaning that if you're compared to your blood pressure being in the 130, 120 range, if your blood pressure is like 140-ish, you just double the risk of stroke. If it's in like 160 range, it's 8 times more. And if you can just lower it by like 10 or 20 points, you just half the risk of stroke. Same thing for ischemic stroke, okay? So I tell people that being able to lower your blood pressure, whatever it takes, medication, cut down your salt, exercise, lose weight, whatever it takes, by 10 points is far more important than whether you're on aspirin or Plavix, or whether your LDL is 70 or 80. This is way more important, okay? And it's easier to do. So, strokes, arteries, heart attack, they're all just plumbing. So I call it brain plumbing. And if your blood pressure is high all the time and you cause a lot of radial pressure on the blood vessel, like the pipe, and you put a lot of cholesterol and put some salt, and then smoking and alcohol, all the bad substance, this is what the artery is going to look like over time. So really, it's all about keeping the pipe healthy. Don't let it corrode and get rust. So this is the kind of a busy slide, but from American Heart Association, basically saying that if you can keep your blood pressure less than 120/80, your lifetime risk of stroke just halved, okay? So whatever it takes, medications, losing weight, anything. And then it says that lowering the top number, the systolic blood pressure, by 10 points can reduce the risk of stroke by more than 40%. Way more powerful than if you're on certain cholesterol medication or aspirin or Plavix. Those are much less important. So I'm going to go through several things that's related to stroke. So sleep apnea, which is actually very common. We think of sleep apnea as just the typical people who are obese, snores, but in fact, thin people, actually, I've seen thin Asian patients who I couldn't believe that person had a sleep apnea. So it can happen. It's not all about just being obese or drinks alcohol. Why is this important? Sleep apnea, you just don't get enough oxygen in your brain throughout the night. And this is a study from UCLA that showed that throughout the night, brain is deprived of oxygen with a weaker blood flow to the brain. And this is the number that we quote. If you have untreated sleep apnea, your risk of stroke just doubled. Your risk of dying from a sudden cardiac death just doubled. Your risk of having a cardiovascular death just overall is 500% increased. And then if you have something like atrial fibrillation, even if a cardiologist fixed it, the chance of it recurring just went up by 57%. So it's easy to treat. Not that many people get used to that CPAP machine, and just by doing that, you can reduce a lot of your cardiovascular, not just the brain, but also the heart condition. Okay. What about? So let's change gear and talk about what we can do at home. So lifestyle risk factors. Besides high blood pressure, these are all the other sort of lifestyle risk factors that can contribute to risk of stroke. So not eating enough fruits, not eating enough vegetables, diet high in sodium, salt, drinking a lot of alcohol, not exercising enough, smoking, and mental stress. And I want you to just kind of look at that list and think about which ones is most important if you were to sort of prioritize, give a ranking, 1 through 7, I guess. Who would say fruits is the most important, not eating enough fruits? What about vegetables? Yeah. Sodium? Yeah, sodium. What about a lot of alcohol? Is that the number one? What about obesity, not exercising enough? Okay. And smoking? And mental stress? Oh, yeah. Mental stress is actually very important. But it turns out it's diet low in fruits. Okay? So number one is high blood pressure. We talked about that. Shockingly, this is one paper, so some other paper makes it. This is how medicine and science works. You have one paper and then 5 years later another paper comes out. But this is one paper that showed that diet low in fruits is globally the second leading cause of stroke. Okay? And if you look at I'm just checking time here. like East Asia or what was it? A high-income Asia Pacific. Where is America? But I think for the most part, it's anywhere from 2 to 4. Okay, so this is actually really good news because it's much harder to cook vegetables. Fruits, you just wash and peel and eat. It's so easy, right? So I'm a busy guy. Like I just don't have time to cook vegetables. So when this came out, I'm like, oh, thank Lord. And it's more. So I felt like growing up, like eating vegetables, like like medicine, but eating fruits was like a dessert, and it's like more appetizing to me. So the question that I get is, which fruits? Does it matter? Actually, it doesn't. So I actually did the research. Every fruit has certain actual compound, antioxidant, something very healthy that makes the blood vessels healthier. And I just want to emphasize that this has nothing to do with vitamins. So some people are like, you know what, I'm just going to get the multivitamin and get that benefit and I'll be fine. It's not like that. It's nothing to do with like vitamins and compounds that you get from over the counter. So each one can, in different mechanism, reduce the risk of stroke. Even lychee and others that I didn't really list here. Okay, berries, so blueberries and strawberries. A lot of the berries are supposed to be really good antioxidant. Watermelon actually lowers blood pressure. Okay, red grapes also keeps the platelets from not sticking together, preventing clot formation, and so on. So just know that every fruit is important. And people say, what about if I have diabetes? I'm not supposed to eat fruits. If you talk to the diabetes specialist, they'll probably say that. They'll probably say don't eat fruits. But from a stroke neurology standpoint, I would say eat a little bit of fruits in moderation is what I say. So what about coffee? Who likes to drink coffee? Me. So the good news is that if you drink 1 cup of coffee per day, you reduce the risk of stroke by 20%. Great news, right? And some people say, well, I thought the caffeine increases your blood pressure. Well, it does and it doesn't. It's not too bad. So I check my blood pressure and it doesn't seem to increase my blood pressure that much. If you're a green tea drinker, you can get the same kind of effect by drinking 4 cups of green tea per day. Okay. The other good news is that drinking coffee reduces the risk of diabetes, Parkinson's disease, and also liver cancer for whatever reason. Okay? So keep drinking coffee, it's okay. Fish has really good fat. It's called omega-3, it's a good fat. And it actually absorbs all the bad fat and bad cholesterol from your blood and then kind of eliminates it. So eating fish several times a week has been linked to lower risk of stroke compared to non-fish eaters. And since I have a little bit of extra time, I'm going to also share extra knowledge here, which may have nothing to do with a stroke. So if your kids or grandkids are pregnant, okay, have them take omega-3 or eat fish, okay? There is like too much fear about mercury poisoning that got kind of spread from like 1950s in Japan when, that mercury sort of scare during pregnancy came from this town in Japan where there were like factories were dumping mercury like into the drinking water, and that's where the scare came from. So the amount of mercury really like in the fish here is minuscule, and then the building block for the brain for the fetus is omega-3. Okay, and you can't get it from animal like eating beef and so on. So either you eat a lot of fish or you take omega-3 supplements, and that's the 2 things that have been shown to change the outcome during pregnancy. One is eating fish or omega-3, and then the other one is exercise during pregnancy. That's it. Nothing else really has been shown. Listening to Mozart near the belly, none of that thing helped with it. But there has been a study that showed that a high amount of fish consumption during pregnancy has been shown with a better verbal IQ, better motor skills, better social interaction for these kids down the road compared to mother who refrain from eating fish. Okay? So I always encourage people to don't be afraid of mercury and just eat fish. Good fish like salmon, not like ahi. Okay. Anyway, tangential, but fish is very important for the brain because that is the building block, omega-3, for the fetus. Okay? And the last slide is alcohol. I'm not going to have you raise your hand, but if you do drink 1 or 2 glasses of wine or beer, anything, as a stroke neurologist, I would say, don't worry about it. It's okay. Just don't get drunk and fall. Because the study shows that having 1 or 2 drinks a day actually reduces the risk of having stroke. Having said that, I'm not going to go out there promoting everyone to start drinking every day, but the risk of stroke goes up after you pass like 2 or 3 drinks, and then the risk kind of takes off. So if you know someone who's a binge drinker, drinking like 6 packs a day, definitely the risk goes up. Okay, but having like 1 or 2 glasses of wine a day, it's definitely not going to increase the risk of stroke. So it's okay. I think ending early to give you plenty of time for you to ask me any questions. Thank you so much for your attention.
We're not going to be serving wine today. I had a question about TIAs.
Yes.
And is that indicative of strokes going to happen?
Yes, thanks for bringing that up. So TIA, medically, it's abbreviation for transient ischemic attack. It's a transient mini stroke. So it's when you get a stroke-like symptoms, whatever that is, weakness, speech problem, whatnot, and then lasts for anywhere from a few minutes to maybe like an hour and goes away. That's a stroke that happened, but luckily the blood vessel just kind of opened up on its own. When you have that, it's very important to get worked up because the risk of having a stroke in the next 48 hours is really high. So yeah, you need to get worked up and be put on the right medication so that you don't have a big stroke.
Let's give Cass another round of applause.